I maybe want to transition to get to a conversation about, again, different mechanisms of action. And so you're working on the BLASST-1 study. This is in bladder.
Right.
And again, trying to add mechanisms of action, I guess, together here. So this is IO plus chemo in the neoadjuvant setting.
Yeah.
So we know, we've had a lot of IO chemo studies in the metastatic setting that have maybe not been so impressive. What's the sort of thought process or rationale in this disease space?
Yeah, so we presented the data for this in the past. So this is patients who had muscle-invasive disease, and it was a single-arm phase 2 trial. So BLAST stands for the Bladder Cancer Signal Seeking Trials. There's a variety of these. And patients received cisplatin gemcitabine with nivolumab. And then, interestingly, there wasn't like additional nivolumab after surgery. It was like the 4 cycles and you're done. And we showed a pathological downstaging in over 60% of patients. But I think one of the key questions we always ask ourselves is like, how do we predict? Like, we're giving therapy in a neoadjuvant setting, we're delaying surgery. How do we find the right patients? Is that there? And so this was sort of like taking a step back and say, okay, we had all these TURs, right? And are there any sort of signs, looking at the slides, like the cell themselves, that may be predictive of response, right? So that was the idea behind this analysis. So using AI, looking at different features in there. And so very interesting that we did the analysis, and there's certain features using AI that were, seemed to be predictive of response, and then went to TCGA and sort of validated, so there's some prognostic association. So really early data, but I think these are the type of things that we need to think about, right? As we move forward, what are those novel biomarkers that help us choose the right therapy? We just talked about cabo-atezo, right? And so what are those, how can we best choose these therapies? As we start doing novel therapies and more expensive therapies and combinations, like who needs this combination, who needs that combination? And I think, it's small studies like this that hopefully lay the groundwork for future analyses that can help us better inform decision-making for our patients.
Right, absolutely. Like from a surgeon perspective, right, the whole notion of neoadjuvant always implies some degree of overtreatment, right?
Correct.
You're always, if you want to give it, if you only give it to the patients who need it, you're missing a whole bunch. So when you're doing it properly, you're going to end up over-treating some of the
100%.
time. And so the better we can do to distinguish those who really need it versus the ones who can maybe spare it.
Right.
Is
Or
just
what about
offers
those
such
patients who
value.
aren't going to respond? And so now you're delaying surgery for 12 weeks or however much, and then they're subjecting the patient to the therapy that may delay, that may prevent surgery, right? I think that's always the concern. I always tell the patients, ultimately, if we progress on chemotherapy, I'm highly concerned it would have progressed after surgery as well, but we never know that for sure. So I think really as we sort of can think about this, how can we best find the right therapy for our patient in all of the diseases, obviously.
Absolutely. So maybe the last question there is, how do you see that fitting in with what we know about adjuvant nivolumab there? So you're adding neoadjuvant nivolumab to our neoadjuvant chemo. Why that regime compared to what we have, phase 3 data with the neoadjuvant chemo and then some adjuvant
I think
nivo.
it's interesting. If we look at the data in the metastatic setting for cisgem neo versus cisgem, we actually have an increase in objective response rate with the addition of nivolumab front. So potentially that we may be doing more. Maybe there is some sort of additive effect or synergistic, we don't really know, but maybe there's something more there, right? And can we get better control up front before surgery? But I do think that this perioperative management of urothelial carcinoma is evolving so rapidly, right? And we're going to have, now we have adjuvant nivolumab improves disease-free survival. We have the ambassador trial being presented here, looking at the role of pembrolizumab in the adjuvant space. And then beyond that, now we have all these ongoing studies that, a majority of patients can't get cisplatin. And so if you can't get cisplatin, what do we give in that perioperative space? And now we have studies looking at maybe EV plus pembrolizumab in that situation. So I think this is such an evolving field, and my hope, is that all these advances we made in the metastatic setting, we can move them earlier and earlier, and if we can use those therapies effectively early on, hopefully we can cure patients and prevent the need for therapy for stage 4 disease.
Absolutely, that'd be a phenomenal future. So I just want to thank you for your time. I really appreciate you joining us and sharing your thoughts on this, late-breaking data.
No, thanks so much for having me.